we will say present and absent, the fourth session. Hookworms. Two main hookworms are in our consideration for medical students and pharmaceutical students. Ankylostoma duodenale and Necator americanus. Ankylostoma duodenale and Necator americanus. Both in males and females. In anterior part, we have buccal capsule. For Ankylostoma duodenale, we have two pairs of teeth. And for Necator americanus, we have two cutting plates. By these instruments, the worms can cut the microvilli of intestinal lumen where they are residing in the human, and they can suck blood to continue their life. So, as a matter of fact, you can find that the consequence of the existence of this parasite in the intestinal lumen is, in chronic phase, is anemia, for instance. Okay. But the posterior end of both worms, Necator and Ankylostoma, the male one, the female posterior end is very simple. But the male posterior end are equipped with copulatory bursa, Necator americanus and Ankylostoma duodenale. The posterior end of both worms, you can see spicules, thread-like spicules. The spicules of Necator americanus are outside, and the spicule of Ankylostoma duodenale as well. So the important is that we have another ankylostome like Brasiliensis, Cielanico, and Canino. All of them belong to carnivores, but in accidental cases, humans can get a type of infection, not like what we can harbor the adult ones. Ankylostoma duodenale and Necator americanus, worldwide distribution. But according to our experience, in Iran, for instance, we can find Ankylostoma duodenale more than Necator americanus in southern part of the country, and Necator americanus more than Ankylostoma in northern part, but not nowadays. As I mentioned for soil-transmitted helminths, in which these two parasites as well are included as soil-transmitted helminth. The history of epidemiology is the same. So I remember even 20 years ago, I wanted to ask one of the students to work on some matters for hookworms, and she decided to go northern part of Iran, where in, for instance, 5 decades ago, nearly 18% of people could be found positive. She could not find even one case. So the title of the thesis changed. This is very important to take into account. Okay. From terms of geographical distribution and the name, Necator americanus is known as New World hookworm infection, and Ankylostoma duodenale is Old World. Although in all of our countries we can find both of them, but in terms of, I don't know, in terms of like taxonomical point, and also what we can describe in terms of genotypes. In terms of genotypes, we have to know that all of these parasites are defined in the separate groups. Okay. In morphology, for anterior end and posterior end, I talked about. Concerning the size, around 1 centimeter in length, both of them. Necator americanus a bit smaller than Ankylostoma duodenale. And also we can say that here, for night soil, I put similar slide in the ascariasis and trichuris trichura. That this is from New York, and you can see here that the company for workers who are working in the mine in some places, they wanted to have their workers healthy. So Ankylosoma duodenale was very important over there, and Necator americanus, and he decided to treat the workers before entering into mine and somewhere to work to get better output of the workers. So this is very important. Concerning the life cycle and concerning the control measures, they are same, because we think about the important points in the environment and as soil transmitted helminth. What does this slide says? You see here, hookworms larvae enter the body through, no, here, let me say, okay. The residing normal site of hookworms is the small intestine of humans. They shed eggs, but after shedding eggs into the environment through the defecation, inside the eggs, larvae will form, and the first stage larvae, rhabditoid larvae, is hatching out, and then after some times, it becomes filariform larvae, which is infective for humans. In the first stage, in the first step, rhabditoid former feed on organic matter in soil, and then after, when it changed to the filariform larvae, a sheet is covered around the larvae, and it cannot feed directly from the material in soil. So it must be entered to the skin of patients as final host and as invertebrate host. When they attach to 37 degrees centigrade skin of humans, the sheet is open and it can go inside the skin. So it means that we may see ground itch, very important here. Who is under this risk? Those who are walking without barefoot, those who are working in the rice field or somewhere like this. So because of that, the situation is completely prepared for entering the larvae, filariform larvae, inside the skin of the patients. Okay, when it become entered to the skin, okay, it forms larvae enter the body through the skin or mouth and pass into the bloodstream. Okay. The larvae travel through the bloodstream to the lungs, like what we described for Ascaris lumbricoides. So you can guess that low-flare syndrome as well we can see in hookworm infection as well. It means that we have two separate phase of infection, one in respiratory tract and the other one in the digestive tract, like what we see for Ascaris lumbricoides. Secretions from the lungs, why? And I told you that it is again back to the intestinal tract, and by the buccal capsule and armed buccal capsule with teeth and cutting plate, they can attach themselves to the microvilli of the intestinal wall and mucosa, and they cut the microvilli and suck blood from the intestine to save and to continue their life, and during which the patient and the parasitosis and the parasitic phase of this infection can result in anemia and other intestinal discomfort. So this is very important to know that all these stages is completely happen inside the body of humans. For changing the rhabditoid form of larvae to filariform takes nearly, I think, 2-3 days. Okay. This is skin penetration. through the veins to the heart and then to lung. I describe it, okay? And then after, you can see that ankylostoma duodenale, ankylostoma dermatitis or ground itch, like occurs at site of entry of filariform in skin, cause dermatitis, okay, and common in as well for Necator americanus. Pathogenesis, when filariform larvae enters the skin, they cause severe local itching, erythematous, papular rash may develop, scratching and secondary bacterial. When you are itching your skin, secondary bacterial infection can be happen as well, because you are in dirty place, you are barefoot, and you are looking for something you are working about, but the bacteria are plenty and other even fungal material or something like that. So by this ground itch, the situation is possible for enter another bacterial agents. So symptoms, clinical aspects. Ground itch, the stage of skin penetration between toes, okay, pneumonitis and bronchitis, which is a bit lighter than what we explain about ascariasis. Why? Because the number of larvae that can enter to the skin of the patients are very fewer than the eggs of Ascaris lambricoides when you are eating in a salad, for instance, more than 100 or more fertile infective stage of the eggs of Ascaris. So it means that when you are facing to the invasion process in respiratory tract for ascariasis, the clinical symptoms may be severe, more severe than ankylostoma duodenale. Iron deficiency, anemia is the hallmark of chronic hookworm disease. Fatigue, diarrhea, weight loss, lack of appetite, abdominal pain, and anemia as well. For respiratory phase, okay, we told you, and there is a term Vacana disease. This is also for Southeast Asia. When filariform larva of duodenale is ingested by oral route, both gastrointestinal due to adult as well as pulmonary due to migrating larvae symptoms are observed. This is just through ingestion of the filariform larvae. Common symptoms include nausea, vomiting, pharyngeal irritation, cough, and dyspnea can be described as Vacana disease. This is the name of a place over there. Anemia and hookworm infection, Ancylostoma duodenale, per each worm, per each day, the amount, the volume of blood that these worms suck, okay, it's very important to calculate. You can see here 0.715 to 0.26 is for ankylostoma duodenale, and I don't know, lesser than this is 0.303 ml day per worm. This is very important. Additional blood loss from bleeding at site of attachment. When they want to enter to the intestinal wall and they suck and they penetrate the wall of the intestine by the tooth and cutting plate, it is itself a means of disturb or a means of destructive effect in the
attachment site.
Oh, okay. Everything I'm talking about is the same in both of them, in Necator americanus and ankylostoma duodenale. But I try to mention the specific one. This is for Necator americanus, new wart health worm infection. Okay, the life cycle is the same, and you can see that the eggs are laid out through the defecation and the environment. If the environment is dry and if it is somewhere that people are not over there, okay, the chain of the transmission is cut. Otherwise, if for instance it is in the rice field workers and in the wet soil environment, the chance of infection transmission is very possible. Adult stage and intestinal phase, sudden and transient pain in the epigastric region, anorexia, shortness of breath, dizziness, diarrhea, weight loss, restlessness, okay. Weakness and lethargy, paleness, eosinophilia, swelling of the face and legs, and reduce the hemoglobin to 3 per 100. Okay, heart palpitation and shortness of breath and pain in the heart area, and also cardiomegaly is possible. Okay, for diagnosis, you have to find the eggs of the parasite in stool samples. Okay? You can find the eggs in the stool samples. But to define the species of the hookworms, if you want to define that, you have to keep them until they become larvae. Because according to the larvae, we can differentiate Necator americanus from Microstoma duodenale. Otherwise, just you can say hookworm infection. So, for the flotation method, which is using the weight of the objects into the liquid, for instance, in salt liquid, and also in other liquid to make the very lighter objects in terms of weight come out. For species determination, stool culture as well, and in terms of epidemiology, we talked about 1 billion people at that time for ascariasis, 800 million people for Trichuris trichiura. Here is 500 million people, up to 1 billion people from this period of time, nearly 40 years. Okay, the amount of blood loss by this group of worms is equal to the amount of blood donation of 1.5 million people per day. Imagine. And specific factors influencing host-parasite association, environmental factors, soil material, sunlight, temperature, water absorption rate in sandy soil is faster vegetation. There is a direct relationship between the rainfall and prevalence. It was why I mentioned to the northern part of Iran, in the Caspian Sea, littoral areas, and also in Persian Gulf and Oman Sea in southern part, in the villages area at that time. So it's very important. Habits and human behaviors, lifestyle is very important, because when all of them are, for instance, with shoes and they are working in factories and something like that, okay? The chance of infection transmission is zero. But when they are barefoot and they are looking in the, working on the field, they may get the infection. For treatment, albendazole 4 milligram orally once, single dose, and in severe cases, it is important, be careful, it is important to prescribe a diet rich in animal protein and iron before starting treatment. When you go to a remote village and you find some children are infected with hookworms, okay, they are very pale in feature, they are look anemic and something, so this is not good to prescribe albendazole before doing something else for them. So it's better to give them enough animal protein and to make them the condition enough capable and possible to receive treatment. This is very important for this matter. Or treatment of dermatological complications as well, thiabendazole ointment is 25 oh, sorry, yes, we have local use for tricholavanus. Infection in Iran. Dr. Amini, peace be upon him, in Caspian Sea, 90% in 1347 in our calendar, in Iranian calendar. Okay, nearly
100 years ago?
65 years ago. In Khuzestan province, bordering Iraq, only Ankylostomia duodenale in 1967, when I was 7 years old. You know my age now. When I was 7 years old, in Khuzestan province, by late Professor Sahbo, okay, Qadirian et al., they reported the Ankylostomia duodenale, and also in Bandar Abbas and Mina of near here, near the northern part of Kish Island, okay? We can see that at that time 65%, only 5% among these number were seen Necator americanus. Most of them were diagnosed as Ankylostomia duodenale. Okay, prevention and control, very easy. Do not walk barefoot on the field that may be polluted by the feces. Okay, please do not consult with each other very loud, because I'm just looking for time of you and to finish it. Otherwise, I'll be involved with, to answer you and to ask you please for silence. Improving farmers' daily behavior during work and constructing sanitary toilets near workplaces, okay? Construction of sewage system, mass treatment. Why mass treatment is and one of the main factor, one of the main measure in control program? Why?
I think it's because when people they have it, they can spread it to
because
other
you are
people.
targeting the main source. You are going to clean the source of infection, okay? So, another worm is Trichoestrongylus. This is also a nematode. And the importance, its importance in veterinary matter is much higher than human infection. But 20 species of this parasite, of this worm, have been recorded in human infection. Even in Iran, in the time of when the Ascaris delmonicoides were very prevalent. For instance, in Esfahan province, in Hamadan province, and elsewhere. So this is also another nematode, intestinal nematode, but in feature they are very thread-like one, and comparing with Ascaris, maybe in one Ascaris we can put 100 or more of this worm inside their body cavity. This is very important, and also they are bursate nematode as well. So in the posterior end of main Trichoestrongylus, we can see the copulatory bursa, similar to what we see in hookworms. But the important is that there is some morphological difference. I will focus on that. Common intestinal parasite of herbivores animal, approximately 34 species are recognized. So you can see here that this is the posterior end of female Trichoestrongylus. The most important difference between these two with this parasite with the bursal capsule of hookworms is the shape of spicules. The spicules of hookworms are thread-like, very narrow one and very long. But the spicules of Trichoestrongylus is stumpy and they have a shape. You can describe the shape of, for instance, my late Professor Mobedi, peace be upon him. He had personal atlas and drawn some pictures similar to drag your mind to the exact species of this Trichoestrogilus colubriformis, for instance, Trichoestrogilus axae orientalis. For instance, one of them was very similar to the horn of a goose, for instance. Some of them were very near to the ear of rabbits or the mustache of Chinese Han, for instance. It was very important in his collection, and if God will, I think if I'm enough lucky, I can publish this atlas, which will be unique in the world. I need some colleagues of mine to accompany me for this very, very valuable work. And the eggs of Trichoestrogilus always they compared with the eggs of hookworms, but you can see that the eggs of hookworms are a bit round one, but this is a bit longer, and you can see that Marula stage here with more than 10s and 15 cells here, by which we can compare them with the eggs of hookworms. Anyhow, so this is the different species of Trichoestrogilus and different shape of the stipules of Trichoestrogilus to help us for differentiation. For the life cycle, small intestine, normal location of Trichoestrogilus, as well in digestive tract of herbivores and cows, cattle, and all of them, they are feeding on the intestinal material and digestive material of the host in human and also in animals. Eggs are passed out, and then after egg can change to the rabdoid larvae, and then after rabdoid larvae to filariform, and then after 3 to 4 days it takes place to form filariform larvae as infective stage for Trichoestrogilus. Concerning the epidemiology, reports of human infections with this species are mainly from Iran, Japan, and Korea, with a few sporadic reports from other areas of the world. Why? This is a question. Why this very prevalent form is just recorded in Iran, Japan, and Korea? Why? I need to hear your answer.
Does it have to do with seafood or something?
No. No. Because 60 years ago, 70 years ago, in all countries, they did not examine everybody. So it means that just we had some parasitologists in these countries, and they did exam, or they wanted to perform such research, so epidemiological work to find the eggs, and they were they loved parasites. So I'm sure that I'm saying this true to you. And the most important one is that in Isfahan we could find let me say, significant number of people. Why? Because on that time, they were looking for Ascaris labyrinthoides over there, and we had a health research station in Isfahan, and very, very renowned parasitologists of Iran spent their time and their age and their life into in this province and its religious area. Okay. So reports from decades ago, it is dramatically declined nowadays. Even one case we cannot find. Even one case. And you can describe it, you can understand it why. This is very important. Okay? For pathology, is known to invade the mucosa, and when large numbers are present in the duodenum and upper jejunum, they may traumatize the mucosa, causing desquamation and hemorrhage at the site of attachment. But the few number of these parasites can do nothing So this is also to drag your mind to the most important point in hematology, that worm burden is very important to see the severity or light appearance of the infection among the infected people. The worms are known to suck blood but do not cause anemia. There may be a mild eosinophilia whenever and wherever you have tissue invasion. You have to expect eosinophilia for the patients. Clinical features, asymptomatic, plenty. But in heavy infection, there may be clinical manifestation. Most patients usually have multiple helminthic infection. I remember that in some cases, the beginning of my work in Tehran University of Medical Sciences on that station in Isfahan, at the same time, the people were infected with Ascaris lumbricoides, Trichuris tricura, and Trichoestrangelus, depending on the number. This is real. It was real. Japanese patients experienced diarrhea, nausea, anorexia, weight loss, abdominal pain, headache, and fatigue. There may also be eosinophilia and anemia. For diagnosis, stool examination, finding the eggs. That's all. Control and prevention. This is also a soil-transmitted helminth. So you have to perform everything you can do for ascariasis, hook forms, and for Trichuris tricura for this type of infection as well. Okay, for treatment, albendazole may also be effective. Why? This is also another good question. Why, please? Albendazole may also be effective. Who can answer this? Why? Because we say that albendazole is curable for and the drug of choice for all nematode helminths. Why?
Because it's a single dose.
Loudly, please.
Because it's a single dose.
No. Take your mind. Use your brain.
Maybe
Use your brain, please.
Maybe there's something common with all the parasites.
No.
Maybe it's an immune thing?
Because it's effective.
Is it possible to ask you if 100 years ago we had a mobile phone, okay, so they could prevent themselves from the danger in the wildlife or somewhere, and you ask, oh, please help me. They have not mobile phone. When Trichoestrangelus was prevalent, albendazole was not discovered, was not manufactured. Okay? It means that nowadays, because we have not enough patients for Trichoestrangelus, we cannot decide whether this anti-helminthic therapy is suitable for Trichoestrangelus or not. But we can say definitely that may also be effective.
So they never tried it? Never tried it?
What?
They never tried it, I mean?
I don't know, I cannot hear.
They never tried it? I mean, the
They never tried
albendazole?
it because since this anti-helminthic drug has been invented, okay, the number of patients were not available to use whether it is effective or not.
So let's say I'm a patient. If you give me albendazole, it will be effective or not?
It will be, yes. It can. Well, this is very important, but my question is something not related to the medical science and related to physiology and pharmacology. This question was something to understand what is your, I don't know.
It's so random.
Okay, no problem. Thank you. We have just one more parasite group left. No, here.
What about that?
Okay. This is filaria. Very important. In Nigeria, it's very
Common.
it's It's much famous among the physicians and health workers in Nigeria than other countries.
Mr. Tatin's late.
What about the
Attending.
Who is talking? Who is asking? What is your question? Loudly, please.
attendance? Attendance.
No, this is by the end of my words I can do that. Otherwise, no. Okay. Filarial infection, filariasis, please. Filariasis. Filariasis, the filarial worms are belong to the group of nematodes. They are nematodes. But let me tell you 2-3 very, very important points regarding filariasis. They are vector-borne parasites with vectors. Vectors can transmit these parasites from this one to this one, from this village to another village, okay? Vector-borne. And it means that the climatological factor and environmental factor is much important than the level of hygiene, than the level of education or something like that. Because this is the very warm place, you are working in the environment without clothes or something, okay? You are going on the trees and you are doing something, and mosquitoes and flies are over there. So this is not related to the level of hygiene to expect the number of patients low or very high.
Mm-hmm.
This is very important. About 600 BC, before Christian, elephantiasis and Bancroftium was described by ancient physicians. Even in the records of Avicenna, you know Abu Ali Sina?
Yeah.
Abu Ali Sina, we can find in his records that in some cases elephantiasis has been recorded by this physician. But it doesn't mean that on that time we had filariasis. This report is telling something else to us. It is saying that Abu al-Sina was not a physician to stay in his individual office and ask for the patients to come and get money and also write the prescription. He was something tabibun dawaran ala tibbi. Okay, and he traveled from southern part to northern part, eastern part to western part. Okay, and he could find the very exceptional cases. Okay, anyhow, the important is that with this filarial infection, let me tell you that I'm going to tell you about 3 types of filaria here. One is filaria of lymphatic filariasis. The residing place and natural place and normal place of this parasite is lymphatic vessels and lymphatic nodes, mainly in around the pelvic places, and the other one is causative agent for river blindness, onchocerciasis, and the other one is African eyeworm, loa. This is very important to take into account. Lymphatic filariasis contains Borrelia bancrofti, Brugia malayi, Brugia timoli. Subcutaneous filariasis, loa, Mansonella esterense, and Onchocerca volvulus. For lymphatic filariasis, the tropics and subtropics of Asia, Africa, and Western Pacific. For subcutaneous filariasis in Africa and south part of Central America. This is very important. Wherever I find something very exceptional to a specific parasite, I will mention it. Otherwise, everything I'm saying here is common for all of them. For filariasis, invertebrate intermediate host is needed because this is vector-borne infection. Borrelia bancrofti, causing agent of elephantiasis. Onchocerca volvulus, causing agent for river blindness. Loa, called as African eyeworm. I will talk about these two very, very forgotten filarial infection. Both of them I could find during my 33 years of experience. I could find two infected cases in Iran. And they are, both of them were among the well socio-economical level because the mosquito are everywhere. And just recently, 1 month ago, I received a sample from one ophthalmologist from Abadan city, and this is also a filarial worm transmitted from mosquitoes, from canids to humans. Okay, Bacteria bancrofti, Brugia malai, similar in many aspects. Okay, and also Coselca volvulus and Loa something else. Life cycle. I promise you, if you look carefully on the look at life cycle picture, you can understand everything. Two phases. One in mosquito, the invertebrate vector, and the other one and into the vertebrate and humans. Okay, so you can see here that mosquito like Culex, like Anopheles, sit on the skin of the humans to get blood, and then after, by accident, maybe they are carrying microfilaria, and they can transmit the microfilaria into the bloodstream of patients, okay, Bacteria bancrofti, Brugia malai, and Brugia timori, and also you can see here that they go through circulation, and finally they become adult in lymph nodes and lymph ducts over there, and they are not oviparous, they are larviparous, so microfilaria are released from the uterus of the females, and microfilaria are everywhere into bloodstream. They are not pathogenic, the microfilaria, they are just telling us that something to help us diagnosis. This is very important. And also, if it is very important for infection transmission, we can ask the patients to examine them for blood, and for Bacteria bancrofti we have periodicity. If you go to eastern part of Africa and you want to examine the very remote area, you are not allowed to examine around lunchtime and say this is negative, because we have periodicity in this infection. You have to ask the patients, to the people, to come to you nearly, I don't know, nearly Asha. Around 9 p.m. to 12 p.m. It is very important. On that time, microfilaria is found in the circulation and you can get it. Otherwise, rest of the day they are into internal organs and you cannot find them. So the adult forms only live in the human lymph system. This is life cycle. For another matter that we can say the major cause of lymphatic filariasis, Bacteria bancrofti affects over 120 million people. Okay? Central Africa, the Nile Delta, South and Central America, the tropical region of Asia, including southern China. Vectors of the genus Culex. You can find Culex everywhere. In Tehran, or whenever the window is not equipped with this, I don't know what.
Screen?
A screen, yes, screen. So you can find them seated on the wall, and they disturb people when they are sleeping. Okay, very important. And Culex Anopheles, the vector of malaria. At the same time, in the same region, they can transmit malaria in malarious area, and also Bacteria bancrofti, and Aedes as well in islands of the Pacific. Okay, and let me show you some morphological, very apparent morphological points for diagnosis. This is Anophel. and this is Culex. Why? Because anophel sit on the wall with this angle, 45. Culex parallel to the surface of the wall. It's very critical and very helpful for distinguishing these two types. And for iris as well, you can find this white blood on the body. And despite of adult ones, you can see that for Culex, for instance, the larval stage into the water, they are living in the water, the surface, they have angle, but for anophel, they are parallel to the level of the water. So this is very important to, if you interested to look for these vectors. Concerning morphology, the adult forms are thread-like and long, okay? But microfilaria are very important for the diagnosis. Based on the sheeted one for Vauchereria bancrofti, Bouloukia malai, and Loa Loa, based on the sheeted one and the cells and the cells of the in the body, you can nuclei in the body, you can define whether this blood smear that you have taken from that patient, it was nearly Vauchereria bancrofti, Loa Loa, or something else. Anyhow, adult females average 82 millimeter, around 8 centimeter, male around 4 centimeter, okay? And adult males and females are most often coiled together and are difficult to separate. This is why they can make abstraction in lymph nodes, in lymph vessel system, and the movement of lymph from upper part to the down part become some abstracted, and then after you may phase 2 elephantiasis or hydrocele from the genital organ, okay, after years. This is very important to know the cause and the reason of this elephantiasis or similar appearance. Okay, for when pathology, manifestations, attacks of lymphadenitis and lymphangitis, fever, pain, and the affected part tender red streaks along with fever and malaria. When the mosquito brought the microfilaria in our circulatory system, they go to the lymph nodes, and over there they become adult, and yes, lymphangitis, lymphadenitis is weakness, and then after fever and malaria. Inflammation of the lymph glands, lymphadenitis, inflammation of the lymph channels, lymphangitis, all of them are very important, and this is the cause of abstraction, and this is the real and the final cause and the only cause for forming elephantiasis in this infection. Chronic stage develops years after initial infection. It doesn't mean that when infected mosquito come to me, okay, 1 week after that I have elephantiasis. Unfortunately, from some patients I received some reports and specimen that, okay, dear colleague, please let me know what happened to this. And I asked, have you ever traveled to these infected areas? I back from, for instance, from Tanzania, and I stayed over there for 2 days, and now this is my leg. No, this is completely ridiculous. So we can define it as somebody who are suffering from renal matters or other non-parasitic ones. Anyhow, okay. No, sorry. Lymphatic filariasis. This is the urine sample. The urine sample of the patients with filaria with Vauchereria bancrofti. Because lymph is mixed with urine. So Chyloria, milky urine with blood before left. For Brugia malai, elephantiasis, everything is the same, but elephantiasis is something happening in the upper part of the near the shoulder and breast and something over there. So this is the only different here, and also geographical distribution of Brugia malai, 13 million people in South and Southeast Asia, and also by infection is endemic or potentially endemic in 16 countries. For Brugia malai as well, you can see here, by the end of this body, in the microfilaria, you can see this nuclei, this cell, and this is for Brugia malai. And for instance, the other one is for Wuchereria bankrupti. You can study these features when you are looking my slides, and that's all. I don't need to put your time on very details. I'm looking for a general understanding and important and getting the important point concerning the infection transmission, pathogenesis, and also diagnosis. This is for Brugia malai, lymphodenema. It is the enlargement of the limbs, consistent irritation of lymphatic vessels leading to blockage caused, and elephantiasis, lower extremities, scrotal swelling, but rare. This is for mostly for Wuchereria bankrupti. For diagnosis, chyloria, getting blood at night time, looking for microfilaria, sheeted microfilaria, and that's all, nocturnal periodicity. This is an easy procedure in endemic areas to identify these two types of microfilaria in blood smear. Lymph node biopsy is possible, X-ray is possible, but we have a test called NOT, KMOWT. KMOWT means that instead of getting just one drop of blood for making it smear on the microscope slide, it's better to get 1 cc or 2 cc of blood and make it with defibrate with formalin solution, and then after centrifuge, and get some sedimentation which can be found full of microfilaria over there. It's very important. So this is formalin and this is sediment, and then by shaking, this does not need to make it in centrifuge. By shaking it, after some 20 minutes, you can get the sediment material containing of microfilaria. Okay, and then after here, treatment, D-ethylcarbamazine. D-ethylcarbamazine is the drug of choice for lymphatic filariasis. It is filaricidal in action, the adult form. Okay, first day 50 mg after food. Okay, and like this. Okay, use of tetracycline to kill the adult form and to kill Wolbachia bacteria, which is having a symbiotic relation with Wuchereria bankrupti. This is another points of view. This is another matter that attracts the researchers to work for. This bacteria, Wolbachia, is living inside the worms, inside the filaria. And we think that they use this bacteria for continuing their life and for their living condition. Okay, if we target this bacteria by antibacterial therapy, it means that we get the source of food from these worms, and they may be died due to famine. This is something I can say like this. But anyhow, other drugs include ivermectin, single oral dose, and recently evaluated drugs include levamisole and mebendazole, and cetirizine is very in the core of the researchers. Epidemiology. Epidemiology, I told about this, very important, but that's right upper right part. 80 vectors. Culex 21 species, Aedes 13, Mansonia 9, and Anopheles 34. This is very important. And prevention, okay, it's very important. When we say that in Vaucheria bancrofti we have periodicity, nocturnal periodicity, it means that the daytime the vectors can scarcely find the microfilaria to get and inject to the other individual people over there. So it means that if you want to protect yourself, it's better to take to be very careful around I don't know 6, 7 p.m. up to night. This is very important. And the other matter is clinical control by treating the people. Why? Because you are targeting the main source of infection, which in this case is female microfilaria. Environmental control by efficient drainage and sewage system to eliminate the mosquito breeding place. Reduction of non-vector contact. The next filarial infection. The causative agent of river blindness, Onchocerca volvulus. If you have traveled to Geneva in Swiss, near the building of WHO, you can see similar status like this. There is 2 or 3 blind people that one young boy is what does it mean?
Guiding them?
Is directing them, okay? Boy that is still not that up to that time is not blind. Maybe some years after that, he is also he will be also blind because of Onchocerca volvulus. This is very important. Blindness. In 1893, it was confirmed as a causative agent. River blindness and vector relation, 1926. Geographical distribution. This is Africa. This is southern part of American continent. Okay, but in these 2 continents, we can see the number of infected people. Okay. In Africa, you can see here, and in America. Morphology and biology. Around 50 millimeter, 50 centimeter, 50 centimeter, they are cold one, okay? Adults live up to 14 years. Restricted to humans, no non-animal reservoir. Transmitted by black flies, not mosquito. Black flies, okay? Simolidae, Simonium damnosum, Simonium nevii in Africa, we have it. Transmitted by black flies, okay? Larvae live in fast flowing water. We have 2 types of water over there. Fast flowing water and stand water. Simonium damnosum is here, and Simonium nevii for the stand water. These 2 different types of vectors. Unsheeted microfilaria. We talked about sheeted microfilaria for Brugia malayi, for Vaucheria bancrofti, and for Loa. But for Onchocerca volvulus, unsheeted microfilaria. This is the cross section, longitudinal section of the parasite. By these ridges on the cuticle, we can 90% diagnose as this worm must be belonged to Onchocerca genus. Life cycle. Okay, Simonium fly injects larvae into human skin during blood meal. Larvae mature into adult worms inside the body of the patient, subcutaneous. They perform a oncocercomato, like a tumor-like one under the skin, and all the coiled worms become adult under the skin here. When they become adult, the female larvae lay the female filaria lay larvae, microfilaria, and microfilaria try to move under the skin to close to some parts, specifically in a global area and near the anterior chamber of the eyes and near the fertilized adult female worms produce microfilaria. Simonium fly ingests microfilaria during blood meal. Okay, microfilaria mature into larvae.